So good afternoon, good morning, everybody, and thank you for attending the UAR webinar, Strengthening Rabies Surveillance, where do lateral flow devices fit? As you all know, reliable rabies diagnosis is essential for effective surveillance and timely public health action. Yet, access to confirmatory testing remains limited in many settings. Lateral flow devices, such as the point-of-care test, can support rabies detection in animals where laboratory capacity is constrained. But of course, their use requires careful consideration. This webinar will present the UAR Rabies Reference Laboratory Network guidance, the overview on LFD test for field application that has been published in August 2025 this year, highlighting what is known about lateral flow device performance, their potential role in surveillance, and the conditions under which they may be appropriately used. So today, we will present, of course, as a RabLab network of experts, the presentation of the guidance document that has been published in August this year. And also, we have invited two speakers, Dr. Andre Kurtzer and Dr. Mary Elizabeth Miranda, to present their field experiences in different settings and to share with us their experiences. So just before we start, I invite the audience to place any questions into the Q&A section, noting that we will have the RabLab members available to help and answer to any questions, both by writing into the chat, but also in person. There will be also time for the speaker to answer specific questions in the discussion time. So then we start with the first presentation, which is the presentation of the RabLab guidance document that will be presented by myself. I hope you can see it. Okay. Okay, so today we will start. I will speak on behalf of course, of the entire network, and we will present the background, the state of the art, and the conclusion arising from our working group. Before we start, I have to disclose some those statements. So first of all, this presentation summarizes the current knowledge of the UAR Rabies Reference Laboratory Network on commercially available point-of-care tests that has been published online. Of course, the mention of specific companies or products of manufacturers and whether these have been patented does not imply that these have been endorsed or recommended by UAR in preference to other of a similar nature that are not mentioned. All commercial kits should be validated according to UAR's international standards. None of the POC tests included in this document are in the UAR register, nor are they as yet specifically described as a primary diagnostic test in the UAR Manual of Diagnostic Tests and Vaccines for Terrestrial Animals. I declare on behalf of the network that there are no conflicts of interest, and the study involved the use of commercially available kits. No financial support, sponsorship, or other benefits were received from the manufacturer or any other commercial entity. Before entering into the proper overview details, we need some background. All of you are aware about the importance of surveillance and possibly laboratory surveillance. Diagnosis of a suspect case is indeed paramount to address a cascade of actions that altogether contribute to the resolution of the case itself, but importantly, they also can contribute to the overall goal of eventually enhancing the control of the disease on a larger scale. However, evidence tells us that surveillance is barely reported to international and probably national authorities, and that countries at the greater risk had the lower rate of rabies testing compared to those at low risk. The lack of consistency and the lack of data in farms lead to the doubts about the actual burden of the disease, thus feeding the cycle of neglect for which poor surveillance data due to under-resources determine low priority for stakeholders and small resources allocated. We can therefore ask ourselves why surveillance is so difficult to achieve. So rabies is an ancient disease and diagnostic methods are robust and available. But similarly to what happened for other infectious diseases, there are no tools adaptable in field conditions and in the absence of specific laboratory equipment. In addition, we are well aware that most cases may occur in areas and communities that do not have access to testing and vaccination, and that especially in endemic or high-risk countries, logistical challenges hinder sample submission to the laboratories. Indeed, fast delivery and turnaround cannot be ensured. In this context, a frequently asked question is, could lateral flow device have a role in enhancing investigation and screening in the field? We have then addressed this question. So the UAR chapter on rabies diagnostic, recently modified, already included at paragraph 1.3.3 a short observation about the actual feasibility of implementing lateral flow devices for diagnostic purpose. The UAR experts already noticed some drawback on the use of lateral flow devices, such as the fact that the various available lateral flow devices have shown highly variable results, some with inadequate or even complete lack of diagnostic sensitivity. Test kits have also demonstrated inconsistency between batches based on the type of diagnostic samples used. Then the paragraph concluded that further improvements in sensitivity, consistency, and validation using appropriate diagnostic samples is still required before lateral flow devices can be recommended by UAR. Okay. So to summarize the state of the art, we noticed that manufacturer instructions were often and are often inaccurate. As for the case of some kits for which several studies indicated that the low sensitivity may achieve acceptable values if the manufacturer instructions are changed. And also considering the impact of a false negative results in terms of public health, we are especially concerned about the lower sensitivity of this test compared to the gold standard techniques. Nevertheless, the importance of using lateral flow devices in the field is acknowledged by the experts, especially in the case of a positive result. So positive lateral flow device results should be a strong indication for bite victims to seek post-exposure prophylaxis. However, negative results should never be used to discourage post-exposure prophylaxis in the case of possible human exposure. So we found several flow when scanning what's available in the market. As you can see, there are several kits available, but importantly, the variety of those kits commercially available also reflects a variety of sensitivity ranges, often unacceptable even for a field test. We then evaluated which could be the factors influencing the performances of the rabies lateral flow devices, and we can categorize them into two kinds of factors. The first one depends on the kits or the batch itself, such as the efficiency of detection labels, the membrane quality, the flow rate, the signal amplification methods, and also the clarity of the manufacturer instructions. But also another important factor is the human factor, so the environmental, but also more importantly, the handling conditions of the kits itself, but importantly also I want to underline that the operator skills in sample collection is of paramount importance for the success of the result. As these kits have a lower sensitivity compared, for instance, to molecular methods, the appropriate collection of the brain material, in particular the brain stem, is paramount to achieve, is much more important to achieve overall and accurate test results using lateral flow devices. Also want to underline three key characteristics to be taken into consideration while selecting the kit and interpreting the results. First is the affinity and specificity of anti-rabies antibody. So please note that the type of this anti-rabies antibody is often not declared by the manufacturer. The limit of detection of the kit is also an important factor, as sensitivity is of most importance. We also recommend that at the central level, the choice of the kit would be taken after an accurate examination of the literature data, and in any case, after in-house validation. As a remark, we also want to underline to users that the control lines in the strips do not represent a positive control line, but it only gives an indication that the detection antibody has flowed correctly. This is also important when interpreting the results, especially negative results in the field. We have then compared lateral flow devices to two other methods, of course, that represents gold standard for the for UAR as primary test for rabies diagnosis. Those methods are, of course, the DFA, the direct fluorescence antibody test, and real-time RT-PCR. I highlighted the pros and cons. Of course, the pros are in green, and in orange the cons, and yellow. Note that despite the lateral flow device kits are less expensive compared to the reagents used for the gold standard techniques and require also minimal training and no equipment, they still have limitations in the intended use, as their use can be admissible as a screening test requiring laboratory confirmation, especially in case of a negative result. Also, I want to point out that in almost all the veterinary laboratories worldwide, the equipment and personnel trained to perform molecular methods are usually already available. And that said so, the use of lateral flow devices cannot be considered as to discourage the implementation of rabies diagnostic confirmation test at the level. Of course, the costs displayed here are indicative as they depend on several factors and may differ country by country. And we must admit that despite looking at the available literature, we found only 2 kits that have evidence of acceptable performance. Importantly, all new products that can be found on the market require a new evaluation before being used. So how can we recommend the application of lateral flow devices as a standalone diagnostic test in rabies endemic and low-income regions? As a first step, it must be clear that the country official veterinary authorities has to recognize the lateral flow device as an official test to accept positive results obtained from lateral flow device testing. Of course, in that case, positive results must be included in the official surveillance statistic. So in that way, also the selection of the test, of the kit, and the protocols must be coordinated at the central level, possibly by the central laboratory. We also identified 2 main options in which we can have to use those lateral flow devices. The first option is the most frequent in the endemic or high-risk areas, is for an animal tested under the frame of a biting incident. In that case, a positive results obtained through lateral flow device testing does not require laboratory confirmation. And on the contrary, it gives the right information to inform authorities and initiate post-exposure prophylaxis. But if the sample tests negative, the decision whether initiate or not post-exposure prophylaxis must be obtained through an accurate risk assessment. In this case, it is compulsory to require the laboratory confirmation that must be treated as urgent with a short turnaround. So again, our recommendation are the 3 following. Never use a negative results to dissuade post-exposure prophylaxis. Confirm negative test results using UAR recommended test at central level, and report positive lateral flow device results as per UAR standards. We also agreed on the possible application of lateral flow devices to screen animals in the framework of passive surveillance, for instance, animals found dead, and wildlife, for instance. And in this case, laboratory confirmation of a negative case is not compulsory, of course, not urgent, but in any case recommended. However, considering that surveillance in endemic countries is mainly due to symptomatic and biting casing, we can speculate that lateral flow device would be a useful tool to implement passive surveillance, especially in remote areas and with low availability of resources and infrastructures. Few other tips to take in mind when setting the use of lateral flow devices are listed here. We underline that this must be used using brainstem only, and that it is strongly recommended to select the protocol and kit with the higher performances. Assess the selected protocol and kit throughout an accurate evaluation by the reference laboratories using, for instance, a field sample representative of the strain circulating or expected to circulate in the country, and mimicking also the quality of field samples collected in the field. And before implementing the use of lateral flow devices, clearly define the purpose of the test, defining who, when, where, and how the test must be used, and also clearly defining the protocol for field surveillance. And last but not least, you have to take into account an appropriate training of the field staff that includes also the collection of the brainstem, which is of paramount importance to obtain an accurate results. So as a last slide, I invite you all to have a look at the guidance that have been published online. Is of course open access, and this presentation today just summarizes the conclusions that have been arisen by the working group. And last, I want to acknowledge all the group of experts, but especially I want to mention the main author of this discussion, who are listed here and are almost all attending the meeting here and can address some or all of your questions. So it's all from my side. I then invite Andre Kötze from the Global Alliance for Rabies Control to present his experience using lateral flow devices. The title of the presentation of Andre today is Implementing Lateral Flow Devices to Improve Rabies Surveillance in Zanzibar, Tanzania. I just want to give you just a brief introduction of Andre. As the Chief Executive Officer of GARC, Dr. Andre Kötzer brings over a decade of hands-on experience in advancing rabies elimination efforts across resource-limited countries. More specifically, his experience lies in designing, implementing, and managing technology-driven solutions that tackle critical challenges faced by national governments and local community stakeholders alike. Thank you, Andre. The floor is yours.
Thank you so much, Paula. Can you hear me?
Yes.
Perfect. So thank you so much for the opportunity to present a very brief overview of how lateral flow devices help to improve the rabies surveillance system in Zanzibar. So just for those of you who don't know, Zanzibar is an autonomous region that forms part of the United Republic of Tanzania. And it's actually a tiny island situated off of the east coast of Africa. And if you look at the slide, you'll see it really is tiny. And I've mentioned that because I think there's some relevance to the talk today and to the overall topic of the webinar. But just as a small bit of background history, up to 2015, the government of Zanzibar implemented mass dog vaccination campaigns, but they relied solely on clinical diagnosis. And they believed they had controlled the situation, and they actively wanted to declare self-declare freedom from dog-transmitted rabies. But as hopefully we're all aware, that's not possible without laboratory diagnosis. So in 2016 and onwards, GOG assisted the government with the establishment of rabies surveillance in Zanzibar. And this started in 2016 with the establishment of the Direct Rapid Immunohistochemical Test, or DRIT, as well as the training on safe sample collection. And when I refer to safe sample collection, I'm referring to using the straw method, the non-invasive or less invasive technique to collect a brain sample. Following on from establishing the surveillance in 2017, a year later, a refresher training was taken in the laboratory, as well as a training on doing an animal rabies risk assessment to identify animals that are showing or exhibiting signs of rabies for then inclusion in the surveillance system, because in Zanzibar, rabies is a notifiable disease. And in 2019, an additional refresher training was done on the safe sample collection. And what we saw at the end of this period is outlined on this slide. So between July 2016 and February 2022, what we saw from this surveillance system was sample collection. And if we notice in this graph, black bars represent positive samples, orange are negative. And what we see is clearly bias towards animals that were clearly exhibiting signs of rabies. And in fact, what we see was that in that period, on average, the laboratory only received one sample per month on average. And in fact, there was 34 months or half of this period where no samples were submitted for rabies diagnosis at all. And if we look at this data and we look at the geographical distribution, where that little red arrow indicates the location of the laboratory, we can see there's a clear bias to collecting samples or rabies surveillance in general closer to the laboratory. And we see an increase in sample collection in 2017. That's the year after surveillance was established and a refresher training was held. And in 2019, when a refresher training was held. But this brings me back to my point of, even as a small geographical space, as an island, we observed limitations of surveillance being restricted closer to where the laboratory is based within the country or within the space. And we knew that if we wanted to support the government, we needed to improve the rabies surveillance system. And obviously, as a first step, we said, well, is it possible to decentralize rabies diagnosis? But within a small island like Zanzibar, it's too costly to decentralize, and it really didn't make sense within that space. So what we did is we acknowledged that lateral flow tests do offer a cost-effective alternative, but in line with what Paula mentioned earlier, it's if they are used in a controlled and correct manner. But the question we had was, would these lateral flow kits actually improve the reach of the surveillance network? And if we look at all of the scientific publications focusing on rapid test kits for rabies to date, they all looked at the diagnostic sensitivity and specificity. And throughout those papers, nobody had ever evaluated whether these lateral flow tests could actually improve the surveillance network's reach. And in fact, there was only anecdotal evidence that said, we believe that they would improve the surveillance, and we believe and we speculate that more samples would be included into the surveillance network with the use of these kits, but nobody had actually looked at that in detail. So we decided that what we want to do is to test this hypothesis. And in 2022, we worked with the government to integrate lateral flow kits into the surveillance system. But back when this was done, there was no guiding documents from UAR. So there was no guidelines as to how to do this correctly. So what we had done was we had developed what's called the Radar Toolkit. And this is really just a standard operating procedure that outlines the use of lateral flow kits for diagnostic screening. And in essence, this toolkit is nothing but a series of best practice protocols that allow a user to perform an initial evaluation of the sample and then send that sample for diagnostic confirmation. So as I mentioned, when this was done, there was no UAR guidelines. And for the purpose of this presentation going forward, please note that every single sample was still sent to the laboratory for diagnostic confirmation, whether they were positive or negative. But in essence, nothing is new here in terms of what this toolkit asked the users to do. Samples were collected in the field using the straw sampling technique by technicians with PPE, rabies pre-exposure prophylaxis. The sample was tested in the field next to the carcass. The result was recorded on a mobile phone application, which allowed that result to automatically be reported to the Central Veterinary Laboratory and captured the GPS coordinates. And as I mentioned, all of these samples were still sent for diagnostic confirmation because there was no guidelines available as we have now. But what we had done was to implement a change in that if the lateral flow test result came back positive, outbreak responses were implemented immediately. That sample was treated as positive, and the outbreak response revolved around that. Any sample that tested negative of the lateral flow kit was immediately sent to the laboratory for diagnostic confirmation, and that sample was treated as positive until such time as the sample was ruled negative in the laboratory. So if we look at this, essentially it doesn't make a lot of sense because prior to the introduction of the lateral flow kits, we asked the technicians to complete protocol 1, the brain sample collection, and protocol 4, the sending of the sample to the laboratory. So through the use of these lateral flow kits, we'd actually introduced extra steps into the field application. So the question is thus, with more work to be done in the field, did these lateral flow kits actually make a difference? So this isn't the topic of my presentation, but to just give you an idea, within the first 22 months, 83 samples were collected using this approach. We only experienced 1 month where there were no samples submitted. And within those 83 samples, 1 false negative result was detected. This had no lasting impact because that sample, as it was treated as negative, was immediately sent, treated as positive, was immediately sent to the laboratory, and the diagnosis was confirmed as positive within 24 hours, and the outbreak response happened. But this was just the efficacy of the lateral flow kit, where our focus was whether it actually improved the surveillance. So on the left-hand side of the screen is that period of January 2016 to February 2022, where only the direct rapid immunohistochemical test was performed. And following on from the introduction of the lateral flow kits, what we saw was an increase in sample submission. And this was sustained for that 22-month period. And in fact, what we saw was the number of samples submitted for rabies diagnosis was 4 times higher once the lateral flow kits were introduced. If we look similarly to the geographical distribution of those samples, what we saw was that the samples were collected and diagnosed from 3 times more wards across the island. In other words, it's still not perfect, but samples were clearly being collected from many more locations across the island. And more importantly, in terms of the rabies control activities, Because these technicians were using the mobile app to record the exact location of the rabies case and subsequently launching very quick outbreak responses, they could target the rabies vaccination to exactly where that rabies case happened. And that could happen typically within the same day of diagnosing that sample of the lateral flow kit. So just a small example on the screen where we have the red catchment area indicating the area that needs to be vaccinated, and the black dots indicate the vaccinated dogs. So it's possible to ensure for the managers of this campaign that the right dog population were actually vaccinated in a timely manner. So in this example, what we saw is that these lateral flow kits had actually made a big difference within the rabies surveillance network in the sampling frequency, which had increased fourfold, in the sampling distribution, which had increased threefold, as well as in sustaining sample collection, with only that 1 month out of 22 when no samples were collected. Following on from this, the UAR guidelines that have come out have provided a lot of practical information that further supports the judicious use of these lateral flow kits, but once again, for diagnostic screening, not for confirmatory testing. And as a result, the Radar toolkit has been adapted to reflect those recommendations. And in so doing, ensuring that using this toolkit, which includes the mobile phone application, adheres to these UAR guidelines so that other countries can also benefit from this improved surveillance within their countries. So thank you so much, and thank you for the webinar organizers for including us. I have added a link to the scientific publication about the work that I published today, and I invite anybody to have a look at that. But thank you so much, and if there's any questions, I'll happily address them. Over to you, Paula. Thank you.
Thank you, Andre, for this very interesting presentation and practical, just sharing the practical activities in Zanzibar. I invite Mary Elizabeth Miranda to speak. The title of her presentation is Rapid Detection and Response, Deploying Lateral Flow Devices to Enhance Rabies Surveillance. Mary Elizabeth Miranda, she's currently Chief Executive Officer of Field Epidemiology Training Program Alumni Foundation in the Philippines, and she has over decades of field experiences on managing epidemics of animal origins, especially rabies, together with World Health Organization for Western Pacific Regional Office, with the Food and Agriculture Organization of the United Nations, and with the Global Alliance for Rabies Control. Over to you.
Thank you very much, Paula, and thank you to the organizers of this webinar. Good day, everyone. Today, I'll be sharing our experience in deploying lateral flow devices, or LFDs, to strengthen rabies surveillance in the Philippines, and how these tools have supported rapid detection and response across a challenging multi-island region in the Philippines. I'm sharing this presentation on behalf of our Speedier team with co-lead Professor Katie Hampson from the University of Glasgow. My slide isn't moving, sorry. Up, there you go. The need for One Health partnerships. Effective surveillance is possible only when different sectors work together. But in many places, this level of collaboration is not typical practice. One Health requires intersectoral and interdisciplinary partnerships, and our work shows what happens when those partnerships truly function. We implemented integrated bite case management in Mimaropa, a small archipelagic region with 5 provinces 71 municipalities, over 3 million people, and 22 different dialects. This region has no land borders with any other Philippine region, which makes disease movement and detection quite unique and very challenging. What made IBCM successful here is the strong coordination between government sectors, civil society, and local communities. When IBCM is working, it is because the One Health relationships are strong. What IBCM looked like in practice. In Mimaropa, IBCM relied on the presence of local partners, including human and animal disease surveillance staff, livestock health workers, local officials and community members, and three simple but powerful field components. One is the risk assessment by public health worker, usually a nurse. Two is the communication and information sharing across sectors. And three, the investigation and sample collection by animal health workers. These basic steps created a reliable bridge between human health and the animal health sector. The tools and technologies that supported IBCM practice. Several tools supported implementation, including simplified dashboards, a peer support group that functioned through a simple cross-sectoral messenger group chat, and field reporting systems. But one tool proved extremely valuable, the use of lateral flow device for rapid rabies detection. In the field, teams use LFDs as rapid diagnostic tests, which allowed them to act immediately when they detected a potential rabid animal. Samples were collected through the simple straw collection technique and then sent to laboratories for confirmatory testing, ensuring both speed and accuracy. We worked with the regional or subnational laboratory and the National Rabies Reference Laboratory of the Research Institute for Tropical Medicine. From LFDs to FAT to genome sequencing. After confirmation, using the direct fluorescent antibody testing, many samples were sequenced, and this allowed us to understand where outbreaks were coming from and track how the virus was moving across the islands. Mhm. Okay. Here we see surveillance data before implementation of IBCM. For example, in the island province of Oriental Mindoro, the data suggested that there were more human deaths than detected dog rabies cases. This tells us that the case detection on the animal side and One Health surveillance in general was very weak at the time. Over the last few years, post-COVID pandemic, rabies reemerged on several islands that were previously rabies-free. But because lateral flow devices were available, cases were detected much more rapidly and more frequently. This allowed local teams to respond before the outbreaks expanded further. Sorry, light isn't moving again. Next. Okay. With improved surveillance, we now see a much clearer picture of how rabies has moved across the region. We also see evidence that mass dog vaccination is working and that improved Mm. And that improved case detection has helped communities become more aware, possibly preventing more human deaths. But continued case detection of rabies means that dog vaccination must be sustained. So across these three different provinces were different endemic circulation and the resurgence of cases and eventual control through dog vaccination. Genomic data shows rabies spreading from the mainland, then moving between islands, likely through ferry ports. Through IBCM practice, we improved early outbreak detection, demonstrated the impact of dog vaccinations, and strengthened One Health relationship and even legislation. After action reviews have supported and developed local solutions, but also showed us that structural issues at national and international levels that still need to be addressed. Over 8 months, the region reported no rabies-related human deaths, and we see a sustained downward trend. However, a new human case was recorded early this month in the island province of Marinduque, which may not be surprising given that more than 100 dog cases were detected since the last human death. Stronger detection has improved prevention, but the risks remain. This figure shows confirmed versus suspect human cases. The key message here is that since 2023, and with more community effort, it has become possible to confirm most of the human rabies deaths through laboratory testing. And this is essential for verification of rabies elimination. In the Philippines, we used BioNote as the lateral flow device and showed nearly 100% concordance with the gold standard direct fluorescent antibody test. This demonstrates that LFDs are a reliable surveillance tool, especially when laboratory access is limited or inaccessible. LFDs detected rabies in dogs and in various other livestock species. The triggers for submission or reporting included unusual aggression or sudden death, often reported by owners or animal health workers or ordinary community members. This indicates increased community level awareness and vigilance. Although the manufacturer's recommendation included only brain sample for dogs, cattle, and raccoon dogs, we used this LFD in other livestock samples that were submitted to the laboratory or reported to the veterinary authorities. And we found that this was also detecting rabies in other livestock species. Interestingly, many submissions for LFDs had no associated human rabies or bite exposure. In Marinduque, which is a subset of the regional pie chart, people requested testing simply because there was a stray dog sighting or a dog showed sudden behavioral change or died unexpectedly. And this reflects a major behavioral shift where communities are now participating more actively in disease surveillance. In summary, LFDs enabled early outbreak detection and response. They are especially useful in remote islands without laboratories. They support rapid community sensitization. They are fast, easy to use, and effective, and true positives can be considered confirmed. They identified positives even in samples that were not suitable for DFAT when the sample arrived at the subnational or the national laboratory. Other provinces are now eager to adopt LFDs. However, LFDs are not perfect. Clinical judgment remains essential, and PEP must always be considered for suspicious bias. Quality assurance should continue for a subset of positive results and all negative but suspicious samples. I'm grateful to all our local, provincial, and municipal health, agriculture, and veterinary staff partners, the national and regional government partners from the Department of Health, Department of Agriculture, Department of Environment, the Research Institute for Tropical Medicine, the University of Glasgow, and the support from the UK Medical Research Council and Wellcome Trust. Thank you all very much, and thank you again to the organizers for including us in this webinar and sharing our field experiences. Thank you. Back to you, Paula. Thank you very much.
Thank you, Mary Elizabeth, and thank you. I want to invite you, Andre, and into screen and our RAB Lab member to discuss about possible questions. I have a questions to my colleague, our expert from the RAB Lab network, that since this topic has not been addressed in my presentation, I wanted to discuss with you why we do not recommend using saliva as a sample to be tested using lateral flow devices, because people often discuss the possibility of using saliva as a matrix for this kind of test, and we know that some of those kits that are available on the market are also sell for the use to screen saliva.
I guess I can go first on this one, and then Thomas or anyone else wants to jump in. There's a couple of reasons why saliva is a very bad sample for most of our diagnostic tests. The first is that saliva is intermittently shed. So even a negative result on a saliva test in a clinically suspicious animal cannot alone be used to rule out rabies, even if you're doing PCR, DRIT, DFA, anything. Another fundamental reason why saliva is not a great sample in animal testing is because if an animal is suspected to have rabies, we really don't want you putting your hands anywhere close to that animal's mouth, or that's another person that's going to have to go get PEP, which we know is limited throughout most of the world. The last reason I would have is that LFDs, while the data we've seen today and in our reports, some of them have very good sensitivity and specificity in brain tissue, they are nowhere near as sensitive as modern day diagnostics, gold standard diagnostics like PCR or the DFA. So you really need a high concentration of virus in your sample to consistently get a positive result in an LFD, which in the brain of a fulminant rabbit animal is usually fine. But in saliva, that concentration of viruses is much lower. If you look at the CT value in most saliva samples by PCR, might be in the 30s. Whereas if you look at brainstem tissue for a rabbit animal, it might be in the teens to lower 20s. So there's a huge difference in viral load between those two sample types as well.
Thank you, Ryan. It was very clear. I have a question to Andre and Betsy from as one of the experts that contributed to this guidance, that you noted that most of your work was before the guidance was available. And Andre, you noted that you had updated your own toolkit. So my question is, what's the impact you think these guidelines will have on people working in the field in the endemic countries? And will there be a big change in any of your projects, and how you use the guidelines?
Thank you, Paula. I think from my experience, and I'm not agreeing with what was happening, whether lateral flow kits were a accredited or recognized test or not did not stop rabies endemic countries from using lateral flow kits. And I had experienced many situations where lateral flow kits were used for diagnostic confirmation, nothing after that. And I think the biggest change from these guidelines is it provides a way for lateral flow kits to be used within a surveillance system, but provides the guidelines for their use. I think we've all seen there's a lot of results for the two providers of rapid test kits that are good, but as we saw in that introduction slide, there's a lot of kits that we cannot say the same for them. And having some sort of guidelines certainly plays a big role in ensuring that these kits are not used for important decision making. And to me, that's the biggest difference that I suspect is, at least when you encounter somebody using lateral flow kits, you can provide them with information that says this is how you use them correctly. And once again, that document makes it very clear that if the government does not recognize the lateral flow kits, your laboratory's role doesn't stop. That role of diagnostic confirmation is still there. And that's, to me, one of the key figures is it says you can use it, but take note of these requirements that involves their correct use.
Paula, can I add to that as well?
Yes.
I think the LFD experience of the last 5 years should be eye-opening, not only to the rabies community, but probably to all of animal health and in the future, probably human health. The diagnostic advances, good or bad, high quality or low quality, they are now moving faster than our international agencies are able to validate and put out guidance. So we had, I think all of us experienced several years of seeing, to Andre's point, seeing countries implement these. At the time, there was statements out saying, do not use these. They're not accurate. There were WOA studies saying, we have validated these tests. They are not good. Do not use them. Countries were using them anyway. So I think this does, we cannot continue to go forward as a veterinary community and as WOA in the way we have gone forward with the last 5 years of LFD validation. The validation process is too slow. We've seen countries will not respect the guidance that is out there on which diagnostic tests are appropriate to use. And we've got to find a way to speed up the review and validation process, not only so that we can get good products used appropriately, but so in your slide, the many, many bad products do not get implemented.
Thank you, Ryan. Mary Elizabeth.
Thank you very much. Well, the realization that there's already a guideline for LFDs has given more confidence to field users, and it has increased really our reach for surveillance using a reliable laboratory tool. And it also has, for our case, we needed to influence the national authorities to recognize and invest in this tool as an important part of surveillance as we are aiming for disease elimination. Thank you.
Thank you, Elizabeth. I have another question to the speakers, of course, but also to our experts about the use of this test to then ship the sample material that can be later on extracted for molecular testing. Do you have any experience on that, and how do you think this kind of sample is adequate or not? Thomas, so over to you.
Thank you, Paula. And we have tested, the possibility of extracting RNA from these strips of these lateral flow devices for both for real-time PCR testing, but also for subsequent sequencing. And yes, this is possible. This is the good news, to be honest. And you can even if you store, let's say, positive LFDs for a certain period of time, either in the fridge or even at room temperature or at higher degrees, RNA extraction is still possible, and can be used for RT-PCR testing and sequencing. The latter can get a little bit more difficult if the LFD is, let's say, stored too long, after initial testing, but RT-PCR testing should still be possible, yes.
Yes.
Thank you, Thomas. And Mary
Yes.
Elizabeth, do you have your experience to share?
Yes, just recently we tried to use the material of the LFD, and we were able to sequence samples from this after 24 hours at room temperature. But our experiments are still ongoing with longer storage time and higher storage temperature, considering we are in a tropical country. So we were successful in sequencing sample from the well of the RDT or the LFT.
Thank you, Mary Elizabeth. Ryan, do you want to share your experience?
Yeah, so what you asked is a good question, but everybody who's going to implement this, they really need to understand why they would be taking an LFD sample and putting it through a secondary test. If you're doing it to validate that LFD result, that might be okay. It's probably appropriate. But if you are doing it to definitively declare a sample negative, that can only be done with the appropriate full cross-section of brainstem with or without aliquots of midbrain. So you could have a setup where you're doing your field testing, saving the kits, sending them back to a lab, and seeing whether or not it's positive or negative by PCR. But that sample type would never be considered an adequate sample to rule out rabies in an animal. So just keep that in mind if that is one of the goals of your diagnostic approach.
Thank you, Ryan, for this clarification. I would invite the participants to put in the chat their experience in their own countries, or if they already use lateral flow devices, and so if how they apply the use of lateral flow devices, whether those guidelines fit into the activities that they already perform, or if they are aware of activities or surveillance activities that are not conducted under, let's say, following the guidelines. So you can even email us, not only today in the chat, but just it would be very important to know what's happening in the field. So if Christine.
Maybe while we're waiting for some of those responses to come in, I have a question for Andre and Betsy. I was wondering if you could speak a little bit more to the training that you did with your study personnel. How was that rolled out? I guess they were, in some cases, experienced in taking the samples, but in performing and interpreting the tests. I was just wondering if you could give a little bit more on your experience. Did you face certain challenges with that? Thanks.
Yes. For us, the use of the lateral flow device was incorporated into the IBCM training. So the IBCM training that we were doing for the local partners was intersectoral. So we brought both of the health and agriculture staff at the municipal and very local level together over a 2.5 day training on IBCM. And the training included the brain sample collection and the health workers were there to observe as well, so that they understand the risk and the complexity, or the way animal samples are collected. But also, immediately after that, we use the same sample to demonstrate the lateral flow device. So it was like integrated training as part of our One Health efforts at the local level.
Thanks so much, Christine. I think it's safe to say that in the example of Zanzibar, that whole process of taking a sample formed part of repeated trainings almost consistently. In theory, nothing about the use of lateral flow kits in the field, the sample collection that flow kit use is difficult, and especially based on the feedback from the operators. But what we had done in the case of Zanzibar was to establish a simple WhatsApp group with all the animal health technicians. And if a sample was tested, a photo was taken of that kit, shared on the group, and 9 times out of 10, it was more to inform the other people of a sample that tested positive or negative. But in any case where that line wasn't super definitive, they used that as an opportunity to discuss the sample. So it turned into, and this was very seldomly, to be honest. I think, as Ryan mentioned, when you talk about an animal that essentially succumbed due to clinical rabies or due to rabies, you have a high viral load in the brain. But in the few instances where it was getting tricky, they used that as a forum to discuss, and they took into consideration the clinical signs that were observed and all of those things. But at the heart of it, the use of the lateral flow kits and the sample collection was very easy to implement. And I think that's part of the reason why lateral flow kits are so widely used up to now, even, is they're not difficult to introduce into a surveillance system.
Right. Right. We also use the peer support group, as we call it, but it's a simple messenger group chat, but not only of the animal health workers, but also the public health workers were also in the same group chat, and across also the regional health and agriculture and veterinary officers up to the local community. So it was a fairly large group chat, but very active and sometimes difficult to follow, but it's very effective.
Thank you.
And
Thank you to the
if I can add to that,
Ryan.
I think, again, I'm excited about LFDs for the future of rabies. There's a lot of words of caution we all really need to kind of keep in mind as leaders of implementation in these validation studies. LFDs might be too easy to implement. And I think we are seeing that in a couple of countries where these LFDs are purchased by private veterinarians with no regulatory authority oversight. Private veterinarians are doing these tests with no expectation or knowledge about how to report official tests or what the difference between a false positive, false negative, true positive, true negative is. There is one country where we have heard thousands, if not tens of thousands, of these kits are being used without any government oversight, without any official protocol. I think that is the dangerous future for a lot of our countries if the governments are not fully engaged, if there are not more stringent restrictions on the ways in which they are implemented and how the governments will deal with positive or negative tests and reporting. But that is because these things are so easy to implement. Also wanted to comment, Andre, on the color change for that positive indicator for anybody that's used these. Any even faint red line is considered a positive. And I do think if we're gonna be using LFDs more consistently in the future, and if we have an opportunity to work with manufacturers, I think there's probably better ways they can demonstrate a positive, whether it's a better reader, maybe a black light reader. Like I receive dozens of pictures of LFDs a week, and quite a few of them are fairly low colorimetric change. I think that's one of our biggest risks of false positives is that colorimetric change being weak but present. Yeah, those are my comments.
And Thomas speaking again. I just wanted to get back to the WAR, guidelines that has been published recently. I mean, we all agree that these guidelines not only strengthen confidence in the use of LFDs now, but these guidelines also aim to make users and governments aware of the risk associated with using unvalidated tests. And that is to be, we cannot emphasize that enough. So not every test offered on the market delivers what it's promised. And that is the danger in using these tests. I think this is something we definitely need to highlight again. So it's not, to let's say screw them, but it is definitely a fact, that we need to take into consideration because most of the people are not aware of those of this information. Over.
Thank you, Thomas. I have another question to us, as expert. Do you think that some of those lateral flow devices, for instance, the 2 lateral flow devices that have been included in the guidelines, showing very good performances, I would say comparable to gold standard techniques, can they, lateral flow devices, be recommended as a gold standard? That's, of course, we are not recommended them as a gold standard technique, but why?
So I can take a first crack at this. 5 or 10 years ago, there would have been an easy path for these. The WOA had a very clear process for validating veterinary diagnostic kits, and it's a very important process. Right now, all of the gold standard rabies laboratory methods, they're not diagnostic kits. They're protocols. They're either commercially available reagents through a standard protocol or self-developed reagents through a standard protocol, but you can clearly describe every step of the process, from reagent development to sample preparation to reading test results. Veterinary diagnostic kits, they're commercial products. We don't know what monoclonal or polyclonal antibodies they're using. We don't know how they're constructed. All we can do is receive these and run some validations and say whether or not we think they work now. So a diagnostic kit is much more difficult to standardize as a community for how we use it and how reliable it is. And it's much easier for commercial entities to just build whatever they want. So I don't think until we have a new way of validating and some more regulatory processes for ensuring continued accuracy and performance in certain products, that we can see these be seen as an official gold standard, which is disappointing because I think at least one of these products, there probably is ample, there has been studies equivalent to the PCR validations that WOA has acknowledged with somewhat similar results. So I think 5 years ago, we might be talking about 1 or 2 of these products being a gold standard test, but because that validation process no longer exists, we don't have a way to do it.
Thank you, Ryan. There are 2 comments or questions in the chat now. The first one is, in Zambia, we have employed the use of lateral flow device to still in pilot districts. The use of lateral flow device has really helped us. It quickens decision as to whether someone exposed to rabies could be put on post-exposure prophylaxis. Definitely, the samples subjected to LFD have results validated by DFA at our central laboratory, the Central Veterinary Research Institute, and the results of LFDs have always corroborated. So I would underline this point that a negative, as I mentioned several times, and as we also explain in our guidelines, we discourage, the negative results obtained by the lateral flow device should never discourage the use of post-exposure prophylaxis. for humans. So in case of exposed patients, we discourage to use the lateral flow device, negative results, as as a choice for not implementing post-exposure prophylaxis in the patient. And from Nigeria, we now use the lateral flow device in our One Health surveillance in Gombe State, Nigeria. We use the straw technique to obtain brain samples. The lateral flow device was very effective in detecting rabies in brain of dogs, but we got negative results when we use in cat and goat samples. All samples test led positive, however, at the National Veterinary Research Institute in WOM using DFA. I would invite Andre and Mary Elizabeth or some of our experts to share some experience on different perhaps results obtained using samples from different species. I have personally some explanation that can be related to the severity of the symptoms, that can be also related to the viral load in the brain material. This coupled with not optimal or suboptimal collection of the brainstem can lead to a false positive of this kind of lateral flow, this kind of tests, such as lateral flow devices. Those tests are sensitive, is true, but they are less sensitive than other gold standard techniques. So perhaps we also notice in some, for instance, dog samples, in dogs that were euthanized at the very beginning of symptoms, that the kit can fail compared to other gold standard, to the gold standard method. So that can be a response. I don't know if someone from the lab or from the speakers wants to add some comment.
Yeah, and Paula, isn't that a troubling paradox for all of us in the rabies field? For these tests to work well, it's better if that animal dies a natural, horrible, excruciatingly painful death on its own because the brain is teeming with virus and we get a good test result. If we have the resources to euthanize early, there's less virus in that brain. That performance probably does go down a bit. And the US CDC did a big validation. It's in preprint. I think I put the link in one of the chats here, but that is what we saw. We actually saw relatively poor, I don't say poor, we saw weaker performance of the LFDs in US dogs. Those dogs tended to be euthanized earlier and had lower PCR CT values. And that's just it is going to be a problem for any modern day lateral flow device. They are not as sensitive as PCR. So as veterinary services improve and more dogs are euthanized earlier in their course of illness, which we hope they will be, we need to keep an eye on how well these LFDs are performing.
Okay, Andre, do you want to respond? Thank you, Ryan. To a question in the Q&A box.
I'll respond to that in a second, but perhaps just Ryan, just in response to what you said, 100% agree with you, right? There's no dispute. And especially in that case of Nigeria, there's so many variables. Was the animal euthanized? Did it succumb to the disease? What was the quality of the sampling taken? And there is 100%, there is an inherent risk when you favor the welfare of the animal by euthanizing, you run the risk of false negative. But isn't that exactly why those guidelines still include diagnostic confirmation for all negative samples? In essence, you are using the lateral flow kit to highlight your positive samples a little bit faster. It's in no way your surveillance framework, right? Your guidelines still say if it's negative, it needs to go to a laboratory for proper diagnostic confirmation with a WOA accredited test, right?
Exactly.
So we could spend another hour or so on this. I certainly see the guidance document we put out right now as interim. More information is going to be, more people will start using these, hopefully appropriately rather than haphazardly like we've seen over the last 5 years. More data and larger scale data will be provided, and we'll update guidance as more, evidence-based is released. But I think one of the unanswered questions for the role of LFDs is that there are also numerous publications showing that using the WHO and WOA clinical case definitions are as accurate as the LFD studies. We have a couple studies where with a proper risk assessment, the WHO IBCM risk assessment, I can give you just with a clinical assessment 95% sensitivity and specificity of an animal. That's through confirmatory testing.
Yeah.
So with that rationale, we would have to go into a debate of what is the value of an LFD if I can look at an animal utilizing 100-year-old case definitions and give you just as accurate of an assessment. But at the end of the day, that sample still has to go back to a lab to have any broader utilization. So a lot of things still unanswered that'll be interesting to explore over the next couple of years. We're only going to answer these with more standardized use of LFDs and publication of those results. But I do think the future of these is probably only secured if they're considered gold standard and we have international agencies that can back up and maintain some regulatory consistency of these commercial products. Thomas.
Yeah, so I was just looking at the question that was asked in the question and answers box. It reads, is there a recommendation regarding modification of manufacturer's instructions for sample preparation and in brackets for the two leading LFDs? So clearly what we have to say is, there is no general recommendation from the WOA network, to, let's say, modify manufacturer's instructions per se, because, against the background of the various LFDs that are commercially available, we can't give that recommendation. But, in the case of the two leading ones, what we can say is that we had discussion with one of the manufacturers, and after a long period of debate, they've agreed, and already to modify, and they already did. So they modified the manufacturer's instructions for sample preparation and for running the sample in the test accordingly. Yes.
Thank you, Thomas. I don't know if Andre and Mary Elizabeth wants to add something. If not, we are going to close the webinar. Of course, we as a RAB Lab, we will keep monitoring all those new regions, new kids, and for the next years. And in case we will update the guidelines in case something will change in the future. I really want to thank all the participants, especially our RAB Lab experts that help us with the discussion. Dr. Andre Kötze, Mary Elizabeth Miranda, and all of you for your participation. And again, let's keep in touch, and we need your feedback from the field, also to identify specific actions to be taken, specific guidelines that needs to be updated or delivered by the scratch. Thank you, everybody.
Thank you.
And have a good day.
Thanks, everyone.
Yes.
Bye-bye.
Bye.